Hi everyone. So this PowerPoint, we are going to be continuing on our fetal anomalies. We're going to be talking about abnormalities that occur with the baby's facial structures and then moving down into the neck and thorax. So a lot of these conditions are going to be associated with those trisomies that we've kind of touched upon, but we haven't really gotten to those specific conditions just yet. So please just hang tight as we continue to move through these PowerPoints. So we're going to be working our way down. We're going to kind of start with the face, work our way down to the neck, and then into the thorax. So first we have an epignathus. The G is going to be silent on this term. This is going to be a very, very rare condition. And what this is basically a teratoma that grows on the baby's face. So it's going to be a teratoma that either comes off of the baby's mouth or off of their neck. So it's coming off the pharynx or the oral cavity. Unfortunately, these are really complicated for the baby because, as we know, teratomas can get really, really big. We're used to seeing them in the ovaries, sometimes in the testicles, but when you have this on a small baby's face, it's going to obstruct their airway. It's going to obstruct how they swallow, how they breathe. So this is going to be something that has to be medically attended to pretty immediately after birth. Like we know with all teratomas, these are going to be solid, complex. They're going to be made up of all different types of germ cells. So here we can see that this is going to be a very large oral teratoma epignathus for this baby. Next, we have macroglossia. So this is going to be one of those conditions that we see if we are trying to rule out or if we're questioning trisomy 21. So trisomy 21 is Down syndrome. This is just a enlarged tongue. So it's a very kind of bizarre thing to have, but this is something that we will classically see with trisomy 21. The other thing that we will see that is part of the face with trisomy 21 that we'll kind of talk about when we get to actual Down syndrome itself is going to be an absent nasal bone. And that's why your profile picture on an anatomy scan is so important. When we're doing the profile picture, we're looking for the relationship of that frontal bone of the forehead with the nasal bone in the nose, and then also the size of the chin, which we'll talk about on our next condition. If we do not see that hyperechoic small nasal bone protruding off of the baby's face, that is going to be an indication of trisomy 21 as well. So we don't have a dedicated slide for that on this, but I will add a picture of what a true nasal bone should look like and what an absent nasal bone looks like to the module itself. So next we have micrognathia. So this is saying that we have an abnormally small chin. This is going to be associated with trisomy 13 and 18, which again, like I said, we will talk about, but sometimes this can be just an isolated random event. So although it is commonly associated with those pretty poor prognosis trisomies, this is something that can just kind of occur for a baby randomly. So here we have a pediatric patient. You can see that that chin is like basically not even there. It almost looks like they had surgery to remove the chin. And as we know, with the underdevelopment of the chin in that region, we could also have the underdevelopment of the larynx, the pharynx. So this is why that baby could potentially have a breathing tube there. Or tracheotomy tube, I guess I should say. So next we have microsomia. Again, we're talking about something that's abnormally small. So this is just talking about the abnormally small face. Now, usually it's only going to occur on one side. And if it does occur on one side, we call that hemifacial microsomia. So this means that one side of the face is abnormally small in comparison to the other side of the face. This is very rare. We don't tend to see this too often, especially in our geographic location. So this is going to be all examples of hemifacial microsomia. So you could see this little girl on the left-hand side. The left side of her face is abnormally small. Let me get my little ruler or pencil, whatever this thing is. So this side of her, hold on. This side of her face is abnormally small. You can look at her mouth and see how it's kind of pulling to the left-hand side. You can even look at her nostril and kind of see that we are being pulled over because everything is small. Same thing with the girl on the right-hand side, except hers is going to be her right-sided face. So everything is kind of pulling towards that right side. Her lip is pulling to the right side, nostril pulling to the right side. And even her eye looks like it's a little bit smaller, a little bit higher than the left side. Now, the boy in the middle, a little bit harder to tell, but if you're looking at his chin is pointing to his right side. So he's going to have right-sided hemifacial microsomia. His lip is also pulling to that right side. His nose is not affected. His eyes, his eyebrows not affected, just like the girl on the left-hand side. But we're really kind of looking at those main facial bones in terms of like our cheekbone, our mandible, and as well as our soft tissues of our face. Next, we have our orbits, so abnormalities with either the spacing of our eyes or just the development of our eyes themselves. So we've all heard of the term cyclops, and this is an actual medical condition known as cyclopia. This is when we have just a single orbit, and instead of having it on one side or another, it is right in the middle of our face. So it's going to be a centrally placed eye, which has failed to divide to two hemispheres, meaning two individual eyes. So as we're growing and as we're developing in those early weeks, we know that we all kind of form our systems from our germ cell layers, right? Our ectoderm, our mesoderm, all of those derm layers and those germ cell layers. We know that we split from that. So all of our organs that are paired are going to start as one organ that eventually will divide and split. So our eyes are going to be no different. If our eyes do not divide and split, then this is when we have cyclopia. And it is going to be located right in the middle of our face. We also can have anophthalmia. This is where we have a missing orbit. We can have small orbits, microphthalmia. And then depending on how our eyes are spaced from each other, again, we learned about our measurements earlier on in the semester where we can do the outer to outer orbital diameter, outer to inner orbital diameter. And this is going to help us to determine either hypertelorism or hypotelorism. So if our orbits are too widely spaced across our face, we are going to have hypertelorism, and if they are too close together, we are going to have hypotelorism. Now, we're not really evaluating for on a routine screening exam. We would only be doing that in cases that were extremely, extremely drastic. When we're taking our coronal picture and we're trying to get our nose, lips, we can sometimes see that jack-o'-lantern appearance of the baby's eyes, where they look like that carved pumpkin. It's kind of like that creepy, spooky picture that we see. If when we're doing that coronal picture, we see those eyes looking either too far apart or way too close together, and then we can do one of those orbital diameters. But for the most part, this is not something that we are routinely evaluating or seeing very often. I apologize, guys. I'm like still struggling with my allergies over here. It's been rough, like even worse than in the springtime, which I don't understand, but bear with me. So when we are looking at that coronal view of our baby's face, we're looking at the nose and lips, like we just said. And the reason that we look at the nose and lips is because cleft lip and cleft palate are extremely common in babies. There's also a very, very high prevalence of these conditions in Asian populations. Asian populations make up a mass amount of the world's population. So we see this very, very frequently all around the world. We have a lot of organizations that will go and surgically repair these babies' cleft lips and cleft palates. There are a lot of organizations that you can donate to that people have for cleft lip, cleft palate, and it really is something that is becoming more and more worldwide known, even though we may not see too much of it here in our own country. So cleft lip, cleft palate, we usually can have one or the other, or we can have both. Now, the most common type of occurrence is just going to be cleft lip. So this is going to be the most common congenital anomaly of the face. Now, cleft lip is when we have failure of our palates to fuse in the middle of the top of our mouth. So this is going to cause an opening that runs from the front of our mouth all the way through our upper lip and then the alveolus right at the junction of our nose. When we have cleft palate, this is when our palatine processes have failed to fuse at the midline also. So this is going to be a little bit more towards the back of our mouth, whereas cleft lip is going to be the failure of the palate to fuse at the front of the mouth, and that opening defect travels up and externally. Our cleft palate is going to pretty much stay internal because it's towards the back and middle of our upper mouth, whereas cleft palate, you may not see it as externally as cleft lip, but it's definitely going to be more severe. So cleft palate, we have to question, okay, how far up is this defect splitting, right? Like how far up is this lack of fusion happening? We know that, right above our mouth, the inner upper roof of our mouth is going to be all of our nose structures. And we know that our brain is so closely related to all of that as well. So although cleft lip looks worse, cleft palate is going to have more complications associated with it. Now, like we said, you can also have both occurring at the same time. So this is going to be, it can be an isolated finding in terms of cleft lip or palate or both, but we are also going to see one of these variations with other anomalies and defects as well. So here we have baby with a cleft lip. You can see very external, that lack of fusion between that anterior upper roof of the mouth heading all the way up towards the base of that baby's nose, whereas the cleft palate is more internal in that roof of the mouth in the posterior and mid region. So how do we evaluate cleft lip and cleft palate on ultrasound? This is why the nose lips picture is so important. So we know that we're going to come in from a coronal fashion. If we have the opportunity to use 3D or 4D, we're going to try to use that, especially if that standard 2D nose lip picture does not look quite the way that we want it to. So basically, I'll go over on our next slide, but basically we see a separation, especially cleft lip, we see it a lot easier. We see the separation of those soft tissues. So that's going to lead us to question something bigger going on. So like we said previously, we can have all different variations of cleft lip and cleft palate. We can have just cleft lip, just cleft palate, or both occurring at the same time. So depending on what variation is occurring, our ultrasound evaluation is going to vary. So it may involve only the upper lip, it may involve the nose, it may involve the inner upper roof palates, and it can extend all the way to the nose. In some cases, can even extend all the way up to the eye. So they go all the way up through the nostril on one side, all the way to that baby's eye. So here's our standard 2D pictures. You can see that soft tissue lip has that fusion defect in it. So we can confirm that this is going to be at least cleft lip from this image. Next, we have a cystic hygroma. So this is going to be something that is going to be highly associated with other bigger issues going on. This is not something that we usually see as an isolated finding. This is not something that we see occurring on its own. This is something that is giving us information about a bigger issue happening. So this is one of the most common abnormalities that we can actually see in the first trimester. And the reason that we can actually see this in the first trimester is because in that first trimester, we're doing a nuchal translucency scan. And as we know, the nuchal translucency is going to be that sliver of lucent space behind the baby's neck. So this is typically where a cystic hygroma is going to occur. Now, this does not mean that the baby has a thickened nuchal translucency. This just means that there is a cystic hygroma occurring in that area. So what this actually is a delayed development or a failure to develop of the lymphatic system, and it is going to occur in the region of the neck vessels. So what happens is you have all of our lymphatics. We know that we have a ton of lymph nodes in our neck and in our upper chest, in our axilla. We know that there's a lot of venous communication within those lymph nodes. We know that the venous drainage of the lymph nodes is very complex, right? It's a network of venous drainage to get our lymphatic fluid out. Now, if our lymphatic system did not develop the proper communication with the venous system, well, that's going to mean that we're not able to drain out that lymphatic fluid as well as we should be, right? So we're going to kind of see this accumulation of fluid in the region of that baby's neck. Now, sometimes we can see this accumulation of fluid on the anterior portion of the baby's neck, but we are usually only going to see a cystic hygroma in the posterior portion of the baby's neck. And that's why we can pick this up in the first trimester, because we're already looking at that area. So we're going to see a cystic mass in that region. And we also want to make sure that we evaluate the nuchal thickening. Now, it's important to remember that this is not indicative of the nuchal thickening. So this is going to make that NT scan a little bit harder to perform if the baby does have a cystic hygroma going on. But we already know that if we see a cystic hygroma, chances are there's some sort of chromosomal or genetic defect already happening. So the nuchal translucency is really kind of just not going to give us any additional information anyway. So here we have the cystic mass that's occurring at the posterior region of the baby's neck. You can kind of see up in this area here that this is where we might start to evaluate the nuchal thickening, but then we get this big old thing right here. And that's going to be our cystic hygroma. Okay, next we have fetal goiter. This is also known as thyromegaly. This is seen in moms who already have a pre-pregnancy thyroid condition. So the baby can acquire that. So they can become either hypothyroid or hyperthyroid, and it can actually be so big that it obstructs their esophagus. So this is going to be seen as that soft tissue mass, pretty isoechoic to the surrounding neck tissues, but we see that pretty large lump in the anterior portion of that baby's neck. Next, we are moving down into the thorax. So one of the most problematic thoracic conditions that can occur for a baby is going to be a diaphragmatic hernia. And everything that we've learned about hernias up until this point has kind of been like, yeah, not a big deal, right? They're a big deal for babies. And the reason that diaphragmatic hernias are such a problem is because it's a herniation of the abdominal contents up into the thorax. So now we have all of these structures that are trying to grow and develop, and we have all of these structures that belong in the abdomen now up in the thorax, and it's not allowing our heart to grow and develop and function properly. Same thing with our lungs. So these babies are going to have heart conditions, they are going to have breathing conditions that normal babies wouldn't have to worry about. So these, although they are problematic, they're not super common. They're pretty random. They're isolated events. We're not really going to see them in terms of like a chromosomal abnormality. And basically what this is, how this occurs is from a defect in the baby's diaphragm. So basically the membranes that are protecting the baby's diaphragm failed to form, causing a weakening of the diaphragm and allowing all of those contents of the abdomen to travel upward. We're usually going to see these in the posterior lateral left side of the baby's thorax. And on ultrasound, we are going to see some bowel in the chest. We're going to see potentially the stomach in the chest, maybe the liver in the chest. But we did say that this usually occurs on the left side. So we're really going to see a displaced heart. That's going to be the big thing that we see. So here we can see this cross section right in that baby's thorax. We can see a nice 4-chamber heart, kind of like a 3-chamber heart, but a beautiful heart view. We can now see that there's all of this bowel, hyperechoic bowel, and liver tissue at the same level as the heart. So we know that this is some sort of diaphragmatic hernia. Next, we have hydrothorax. This is also known as a pleural effusion. So this is when we get fluid in the pleural cavity. You guys know all about this in adults, and that's why we're doing thoracentesis. So babies can kind of get these randomly as well. Unfortunately, they have a pretty poor prognosis. Um, it's about a 50% mortality rate, and that is because we have all of this fluid that is kind of compressing and limiting the development and function of the lungs and the heart. So that's going to lead to further complications as that baby gets closer to being full term and potentially being born. This can be one-sided or bilateral, just like pleural effusion in an adult can be. And here we can kind of see that sagittal view of the lungs, quite a good amount of fluid in that thoracic cavity, kind of creating that free-floating appearance of the lung. Next, we have CCAM. This is congenital cystic adenomatoid malfunction. This is a type of solid lung mass, but it is not cancerous. So this is going to be a multicystic mass that we can see within the lung. It's going to be comprised of lung tissue and abnormal bronchial structures. It is variable in size and composition of cysts. So as we know, cysts can have their own size to them. We could see this in one lobe of the lung or multiple lobes of the lung or at the entire lung, but seeing this bilaterally is very rare. So usually we're only going to see one lung or one portion of one lung starting to develop this condition. So here we can see again another sagittal picture of our lung tissue. This is going to be our cecam right here. It's accumulation of little cystic regions, but it does represent a solid mass. Next, we have bronchopulmonary sequestration, another type of solid lung mass. This is going to be when we basically have like an accessory lung, kind of accessory spleen, but this is non-functional. So this does not help with the lung function. This does not help with practice breathing. It's basically just an extra lobe of lung tissue that is going to be separate from the normal lung anatomy. So here, very, very hard to see and not something that we are going to be seeing on ultrasound too often. But here we have left lung, not the greatest evaluation of it because at this level we're getting more of our heart on that left side. And then we have right lung. And then we have accessory lung. So if I erase my accessory lung, and you look super, super closely next to the border of the right lung and the accessory lung, you can kind of see a very faint, very skinny hypoechoic line. That's differentiating between the right lung and the accessory lobe. Next, we have pulmonary hypoplasia. This is going to be the underdevelopment and the underfunction of the lungs because we do not have as many lung cells as we normally should. So we have very small lungs, reduction in lung volume. Of course, this is going to lead to complications for these babies, and it's typically going to be caused by prolonged oligohydramnios, or if the baby just has a small thoracic cavity for whatever reason. Of course, those lungs are not going to be able to develop and grow properly if they don't have the space to do so. So prolonged oligohydramnios, right? We don't have enough amniotic fluid, so the baby can't practice breathing. Well, that's going to lead to underdeveloped lungs, right? The more you practice, the bigger, the better, the stronger the lungs are going to become. If you don't have amniotic fluid to practice, well, then you're not going to have normally developed healthy lungs. Next, we have pulmonary atresia. So this is going to be a congenital heart defect where the pulmonary valve does not form properly. Of course, it's going to play a large role into the circulatory system of the baby. As we know, our pulmonary valve is what is going to be able to send blood from our heart to our lungs to be oxygenated. So of course, if that's not working properly, we're going to run into some secondary complications from that. Next, we have cystic lung masses. So we talked about some solid lung masses, the bronchopulmonary sequestration, the cecam, both solid masses. Now we have these cystic lung masses. So we have a bronchogenic cyst. Again, these are not going to be types of cancers. This is the most common prenatal lung cyst that we can sometimes see, but that occurs in babies. It's actually going to replace normal lung tissue. So unlike normal cysts, where normal cysts kind of just displace the tissue, in fetuses and in babies, these lung masses are going to replace that lung tissue. So it's not going to cause any kind of shift or potential heart failure, and it does not communicate with the trachea or the bronchial trace. So although it's not going to have this secondary effect on our heart, we do have to keep in mind that although it may not be problematic in that sense, it's going to be problematic in the sense of like, okay, well, now you took away the normal lung tissue, the normal functional lung tissue. So my lungs is probably not going to be able to function as well as I want it to. Next, we have echogenic intracardiac focus. So this is something that is kind of getting phased out of ultrasound in the OB world, but we still kind of question it. So this is going to typically be a normal cardiac variation, and what it is literally an echogenic intracardiac focus. We see an echogenic little dot within one of the chambers of the heart, and previous literature really associated it with a lot of trisomies and chromosomal conditions and Down syndrome to be like the number one association. It freaked out a lot of moms, freaked out a lot of people, and it sent a lot of people for level 2 exams. And we're still sending these patients for level 2 exams if we see it. We're still sending them for a fetal echo, but we're way less worried about it. So a lot of babies will have these little hyperechoic foci in the heart, and it ends up being absolutely nothing. Now, we still will have those random cases where we do see it genetically linked to something, but the numbers are drastically dwindling for that. So again, this is kind of like not controversial information, but it's kind of like we're trying to figure out what we're going to do with it because we've kind of worried about it for so long that it's really not proven anything, that we're kind of just phasing it out over the next few years. So here we have intracardiac echogenic foci or focus right there. Usually are only going to see one in one chamber of the heart. And again, it's not something that we are ignoring. We're still sending these patients for fetal echoes and level 2 ultrasounds, but this is something that literature definitely varies on today. Next, we have Tetralogy of Fallot. So this is going to be the most common form of cyanotic heart disease. So this means that we are just getting an absolute lack of oxygen to the heart. And in order to be classified as Tetralogy of Fallot, you have to have these 4 defects, these 4 things that are happening with the heart. You have to have a VSD, a ventricular septal defect. You have to have pulmonary valve stenosis. You have to have a displaced aorta, and you have to have right ventricular hypertrophy. So if you have all 4 of those, then we have Tetralogy of Fallot. Now, if you are working in a standard OB world, you are not going to be performing this. You are not going to be looking for Tetralogy of Fallot unless you are certified in fetal echo. So this is something that fetal echo is going to be done for. We'll be able to confirm that or rule that out completely. But when we're doing our 4-chamber heart pictures in the anatomy scan, we want to be looking at how thick those walls are. We want to be looking at the valves that make up the chambers, right? So if something looks abnormal to you, well, you need to document that, question that, so we can send that patient for a fetal echo. So here we can see our ventricular septal defect between the right and left ventricle on the right-hand side. And then we also see right ventricular hypertrophy on the left-hand side. So if I'm right here, a little pencil, definitely thickened. Can't really see it on the right side of the picture. Next, we have Pentalogy of Cantrell. So sounds similar to Tetralogy of Fallot. Pentalogy of Cantrell. This is going to be rare, and what this is a cleft in our sternum. So we have this abnormality of our sternum, which is supposed to protect our thorax, and it allows for basically an anterior hernia to protrude through. So we get this diaphragmatic hernia that has the displaced heart. We have this herniation through our anterior chest wall, and then we have the potential risk of ectopia cordis. Ectopia cordis is probably one of like the scariest things that I've ever seen. And a lot of these kids grow up, develop fine, have lots of heart surgeries, and are okay. But to me, it's one of those things that's like very hard to wrap my mind around. So, Pentalogy of Cantrell. All this diagnosis is a cleft in our sternum that allows for the potential herniation through our anterior chest wall. Ectopia cordis is when our heart comes through that defect in the sternum. So now our heart is sitting outside of our chest. So different conditions, but Pentalogy of Cantrell allows for ectopia cordis to occur. So here we have both images of ectopia cordis. We can see on the left-hand side. Actually, I take that back. Picture on the left-hand side, I cannot confirm if that's the heart that is coming out or if that is just thoracic tissue coming out. So that could be lung tissue coming out. That even could be abdominal contents coming out through the diaphragmatic hernia where it came up into the thoracic cavity and then out through the defect. So cannot confirm that that is a heart outside of the chest wall. But you can see the little defect in the sternum is right here. And then the picture on the right-hand side, this is of an older patient with ectopia cordis, probably a pediatric patient or a young teenager, who we can see the heart is literally protruding out through the chest wall. So very, very scary condition. Again, a lot of these cardiac conditions we are not ruling out in a standard OB practice or in an OB hospital. These are going to be things that we question something not looking quite right with the four-chamber heart or the outflow tracts, and then we send that for fetal echo. We send that to, a step further. I am going to post an additional PowerPoint in the module as well about outflow tracts, how we actually perform them, because that is something that a lot of OB practices are starting to implement, and it does help with determining if there are any underlying cardiac conditions happening. So like we saw with Tetralogy of Fallot, one of the defects that you have to have is a displaced aorta. Well, how do we know if it's displaced if we're not looking at it, right? So our outflow tracts are going to be when we're looking at our aorta, when we're looking at our pulmonary artery. We're going to be able to determine some of those things and then be able to have a better understanding of what is going on and why we would need to send them for a fetal echo. So please take a look at that PowerPoint. If you have any questions about that PowerPoint, please do not hesitate to ask me. I'm not going to have a recording for it, but you will be responsible for that information. And then I will be posting some images of the nasal bone as well in the module.